We're going to get started on the lecture with heart blocks and pacemaker rhythms. Heart blocks, when it's the first degree and second degree type 1, it's not a serious arrhythmia. However, the rest of the heart blocks are very serious and life-threatening. So it's good to be able to recognize all of those. With first degree heart block, it says the distinguishing features are, you'll look at your strip and you'll see a normal sinus rhythm, but the PR interval is going to be longer than the normal 3 to 5 boxes. And then conduction through the AV node is delayed. That's what gives that PR interval a longer period of time. So you look at your rhythm and you notice that it's regular. The heart rate is regular. You see P waves, there's one before each QRS. But then when you look at the PR interval, it's much longer than the 3 to 5 normal boxes. So this is called a first degree heart block. So there's no treatment required for this heart block, and the patient will be asymptomatic. So they're not going to be experiencing any chest pain. Blood pressure will be normal. With second degree heart block, there's 2 types. There's type 1 and type 2. Type 1, it says that each impulse has more and more difficulty passing through the AV node. The PR intervals will become longer until an impulse is not conducted at all through the AV node. And it has 2 names. It's called second degree type 1, or you can call it Wenckebach. And then for causes, this can be caused by an acute MI, so you have some infarcted muscle in the heart. It can be caused by drug toxicity from digoxin, from calcium channel blockers, from beta blockers. Electrolyte imbalance will also cause second degree type 1. And then head injury can cause irregular heart rhythms, such as second degree type 1. All right. So looking at the strip, you see the PR interval is, here it's longer than 5 boxes. Here it's even longer. Here, even longer. And then the next, you see a P wave, and there's no QRS at all. So the AV node it's accepting an impulse, but it's not responding to it. And it becomes less and less responsive, and all of a sudden it wakes up and starts over again. You get a normal PR interval, but then it can't keep doing the conduction very well, and it's almost like it gets tired. And then the next time, the conduction takes even longer to get through the AV node. And then again, an impulse won't get through it at all, and then it wakes up and starts over again.
I have a question. So it goes like progressively getting longer, and then it skips the QRS?
Yes.
So that's how it is always?
Yes.
There's going to be a missing QRS?
There's going to be a missing QRS, yes. So this shows there's 1, 2, 3, and then the 4th impulse is blocked, but it's not always 4. It could be different amounts before you see a blocked QRS.
Can this be reversible?
The infarct cannot, no. So if it's caused by calcium channel blockers or beta blockers, stopping the medication will make the rhythm go away. If the digoxin level in the body is too high, getting a normal dig level would stop this arrhythmia.
And are the causes the same? For type 1, is it the same for type 2?
Are you ready for type 2?
Yeah.
Okay. All right, so second degree type 2, the distinguishing features are failure of sinus impulses to be conducted through the AV node to the ventricles. So you'll see more than one P wave before each QRS. So there will be a P wave and it won't conduct through, so you'll be missing a QRS. Another P wave, and oh, that one conducts through, and then you'll see a QRS. So you'll see more than one P wave, and then you'll see a QRS. So the ratio could be 2 P waves to 1 QRS, or you could see 3 P waves to every QRS, or 4 P waves to every QRS. So if the patient is symptomatic, a pacemaker is indicated. And then it asks you, what is a pacemaker? All right, there's just some notes to write before we write down what a pacemaker is. It's good to note that this is a serious arrhythmia. It may progress to complete heart block. So this is not a rhythm where you say, oh, 2-to-1 conduction, 3-to-1 conduction, no problem. It is considered a serious arrhythmia, and it does need to be treated. And then for the causes, it could be an anterior wall MI because the left coronary artery is occluded. Or it could be degenerative changes in the conduction system. Do you already have that in your notes?
Yes. Hyperkalemia, meds, and drugs.
Say that again?
Hyperkalemia is also one, and then drugs is a cause.
No, I don't have that.
So you said anterior wall, MI, and degenerative change in the conduction system.
Yes.
Those are the two which are the causes.
Yes.
Okay. Okay.
All right, so what is a pacemaker? Consider it a small EKG monitor that is attached to the heart with wires. It also has a defibrillator in there if it needs to defibrillate the heart. It'll apply an electrical current to the heart, which will initiate an impulse. So in this case, if you've got the atria doing a fine job, there's conduction's going through normally, but it's being blocked and not communicating to the ventricles, what you need is a pacemaker to stimulate the ventricles to depolarize and then contract. So the type of pacemaker would be a ventricular pacemaker. All right, looking at the EKG rhythm for second degree type 2. It's regular. You see P waves, but you don't always see a QRS. So here you've got 2 P waves and then a QRS. 2 P waves and then a QRS. 2 P waves and then a QRS. So what would the conduction ratio be for this rhythm? 2 to 1. So you would say second degree heart block with 2 to 1 conduction. All right, the next heart block is complete heart block or third degree AV block. The distinguishing features are complete absence of conduction between the atria and the ventricles. The atrial rate will be regular and the ventricular rate will be regular. So if you use your piece of paper and you mark all the QRSs, you're going to say, okay, that's regular. You're going to mark the P waves. Okay, those are regular. But you'll notice they don't communicate with each other. The ventricular rate will be regular, but it's going to be slow. Remember, if the ventricles don't receive an impulse, they'll initiate their own impulse, but the rate is going to be slow. So 20 to 40 per minute, and your QRS will be wide. Those are the distinguishing features. So maybe you can circle that or highlight it or put a star in front of it. The ventricular rate will be 20 to 40 per minute. And the QRSs will be wide. And when you look at the PR intervals, it's going to look like they're all different ones. It might look like they're too close, and then it'll look like they're too far, but there's really no communication between the two. So the treatment for a complete heart block is a pacemaker is needed. And then for causes, it's caused by coronary artery disease leading to infarcted heart muscle. And it can also be caused by the same drugs that caused second degree type 2 or type 1, digoxin, calcium channel blockers, beta blockers. All right, so let's take a look at this rhythm. So you look at it and you see that it looks regular, and if you measure the R to R intervals, you'll notice those are regular. The QRS is wide, and it's slow. This is a 6-second strip. 1, 2, 3, 4. So the rate is 40 per minute. So wide QRS, it tells you that the impulse is coming from somewhere in the ventricle to stimulate the ventricles. And the fact that it's slow tells you it's an impulse inside the ventricles. Then when you look at your P waves, you see P waves. But the PR intervals are crazy. Here's a long PR interval. Here's a P with no QRS. Another long one. This one looks a little shorter. So the wide QRS, the slow rate, and it appears like PR intervals are going crazy, but there's just really no communication. The atria are doing their own thing, and the ventricles are doing their own thing. And there's no communication between the atria and the ventricles. That's complete heart block. So this is a rhythm that gets missed a lot with testing. So we're going to give you lots of practice so that you'll recognize this. Okay, let's practice our newly acquired skills. Oh, you already wrote it down?
Yeah.
Okay. So this looks irregular. Do we have P waves?
Yes.
P wave, P wave, P wave. Yeah, so there's P waves, but sometimes there's no QRS. All right, what about the QR interval? Did I say that right? The PR interval? So here it's long. Here there's a P wave and no QRS. This looks normal, but this keeps getting, so the PR intervals are getting longer and longer, and then there's a missed QRS.
Second degree, type 1.
Very good. So this would be second degree heart block, type 1. And we notice that there's problems with the AV node, and it's not always conducting, and then it resets itself. All right, the strip on the bottom. It's not much of a QRS on this strip, is there? So P wave. So there's a P wave before each QRS. It's a regular rhythm, The PR interval is 8 or 9 boxes. So long PR interval, but there is a Pwave before each QRS. You have it written down? You don't have it written down?
It's first degree.
First degree heart block. The only abnormality that we're seeing is the long PR interval. So that would be first degree heart block. So this is asymptomatic, doesn't need treatment. Okay, the next strip looks regular. We see P waves, P wave, P wave, P wave, P wave, P wave. So there's a P wave but no QRS. P wave, QRS. P wave, no QRS. So it looks like there's 2 P waves for every QRS.
We're trying to figure out how you would properly say this, the name of it, because we see 2 P waves before QRS. So it's 2 to 1.
2 to 1.
2 to 1 conduction.
Yeah.
Yes. I got that. All right, the one on the bottom. Wow, look at those wide QRSs. Do we have any P waves to go with it? And we do.
We do.
The fact that the PR intervals look like they're all over the place is the hint that we are looking at complete heart block. So the ventricles are doing their own thing and the atria are doing their own thing, and there's no communication between the two. So this is complete heart block, or 3rd degree heart block.
And the treatment for that is pacemaker?
Correct. Yes. What is the treatment for the rhythm above, the 2nd degree type 2? Pacemaker.
Oh, pacemaker?
Yeah. Okay, the next strip. See, looks regular. We see normal QRSs. Looks like we've got a ST segment depression by 1 millimeter. So there's must be some infarcted heart muscle. P waves. There's a P wave before each QRS. But the interval is really long. They're all the same.
First degree?
Yes. Does everybody agree? It's 1st degree heart block? A long PR interval is the only abnormality that we see, other than the depressed ST segment. Okay, good. All right, and then the one on the bottom, we see a wide QRS and a slow rate. So that tells us that the impulse is being initiated inside the ventricles. And then the P waves look very regular. So the P waves are doing their own thing and the ventricles are doing their own thing, and we'll come to the conclusion that it's complete heart block. So how would you treat that? Pacemaker.
What about 2nd degree type 1? Is the treatment for that is also?
Type 1 usually doesn't need a pacemaker if it's caused by medications. Stopping the medications. If it's caused by electrolyte disturbance, then you have to get the electrolyte, potassium or calcium or magnesium. All right, so pacemakers. They show up on an EKG strip as a solid straight line, so you can tell when there's a pacemaker initiating the impulse. Pacemaker wires can be temporary, and if they are, they'll be threaded through the subclavian vein. So there will be an IV going into the subclavian vein, and they'll just run the pacemaker wires through that IV, and that will stimulate the heart. And then the pacemaker device will be external. Or permanent pacemakers are actually implanted underneath the skin. So there'll be a little box. I don't know if you've seen that on any of your patients or palpated it on your patients. But the box will be under the skin, but there's wires going to the atria and ventricles. So atrial pacing, you'll see a spike right before the P wave. Ventricular pacing, you'll see a spike right before the QRS. Or if it's AV sequential pacing, you'll see a spike before the atria, before the P wave, and then a spike before the QRS. All right, so this is showing not much for P waves, but it's showing a spike before the QRS. You see that solid black line right before the QRS?
Yeah.
So that tells you that the pacemaker is stimulating the ventricle and causing it to depolarize and then contract. So what type of pacemaker is this? Yeah, ventricular pacemaker. All right, here's a pacer spike before the P wave. So it's called atrial pacing. A spike before the QRS is ventricular pacing. And then if you see a spike before the P wave, a spike before the QRS, you're looking at atrial and ventricular pacing. All right, so when you're looking at an EKG, sometimes you see unusual waves, and the unusual waves can be caused by imbalance in electrolytes in the body, specifically potassium and calcium. So when there's too much potassium in the body, you'll see peaked, narrow T waves. So the way that I remember that is I say, there's high for potassium, you have peaked T waves. And then you have to kind of spit as you're saying it, and it becomes a memorable experience. And you'll always remember peaked T waves are from high potassium. Right? So you won't get that wrong on your test.
Peak potassium.
I have a different way of remembering it, not as
What is your way?
for high potassium, the T waves are pointing up and for low they're pointing down.
I can't stand some
For why are they pointing down?
High potassium, they're pointing up, saying the potassium is high.
Uh-huh.
And low potassium, they're pointing down, saying it's low.
Ah, okay.
I like your mom, Johnny.
All right, so for low potassium, the ST segment will be low, and then you'll see an extra wave, a U wave. All right, so here's the tall T wave for the high potassium. Eventually, with even more potassium, it causes the QRS complexes to widen. So it almost becomes indistinguishable from the QRS and the T.
That's from high potassium?
Yes.
Okay.
Yeah, if you've seen open heart surgery and they're going to place the blood through the bypass pump and stop the heart, have you noticed how they stop the heart?
Potassium.
Yeah, they give a lot of potassium, and that eventually stops the heart. So you'll see this change in the EKGs, and then the heart will stop. All right, so with the low potassium, you see that the T wave is flat, or that low T wave, as Raj was saying. And then there's a U wave. So you see it twice after the QRS. And when it's really low, now you see it below baseline. And the U wave becomes much more prominent. With calcium being too high in the blood, it's going to cause really short QT interval. So you'll get a QRS and a T, and it'll take place in a much shorter time period than normal. So how short is short? It's less than 0.36 seconds. So if every little box is 0.04, 4 times 9. It'll be less than 9 boxes for everything to occur. And that's considered short. When there's not enough potassium, you see a real long QT interval. I don't have any way of remembering that.
Can you repeat the numbers?
The numbers aren't real important.
Oh,
Yeah, so you won't have a test question on the number. I'm just trying to show you how short the QT interval is compared to normal. So a normal QT is 0.36 to 0.44, and if it's just shorter than normal, then you would suspect that the potassium is high. And then with low calcium, it's real hard for the muscles to repolarize after they depolarized, so it takes a lot longer for the muscles to repolarize. But how can you remember that? Do you have a way, Raj? No? I don't have a way with calcium either.
Just need to know.
Okay, good enough. All right, with 12-lead EKG, respiratory is, in some hospitals, responsible for running 12-lead EKGs. And the machines that you use, you get trained on, and they're pretty simple, and every machine is different. So we don't have any in the lab for you to practice on. So you will be trained at the hospital that you're working on with the EKG machine that you're working with. But attaching the leads is universal. So we're going to go through attaching the leads and how you would attach the leads. And then to read a 12-lead EKG, it's a 6-week EKG course. So I just give you a few of the basics. You know, this is what it looks like, this is what they're looking for in the 12-lead, and that's pretty much it. One thing with a 12-lead EKG is you're getting a more complete picture of the heart's electrical activity. So instead of the typical 3 leads on the anterior chest, you're going to see different angles of the heart, and therefore you can see different abnormalities. So it's a 12-lead EKG, but there's really only 10 electrodes that you place on the body. So you'll put 6 on the chest and 4 on the limbs, you know, arms and legs. All right, the chest leads are called the V leads, V1 through V6. And then the limb leads are the same as we've talked about in the past. If you put it on the left arm, it's LA, the right arm, RA. The right leg is the ground, and then the left leg. And then they have extra names added to them. Did you label your picture already? Like the right arm is also called AVR. Is that too tiny on your paper to add it?
Sure.
You can write it in bigger letters.
Right arm.
So the right arm is called AVR. And that stands for augmented V lead on the right. AVR. And then on the left arm, it has another name, AVL, for augmented V lead, left. And then the one on the left leg is called AVF for augmented V lead on the left foot. I don't know where the F comes from. Foot, I guess. Augmented V lead on the left foot. AVF. Go back.
Oh, the ground is just the ground?
The ground is just the ground. All right, so having the limb leads, you can get lead 1, lead 2, lead 3. We've already talked about that. How the machine will assign a negative charge to one, a positive charge to the other, and look at the heart through that. The AVR, AVL, AVF, those are unipolar leads, meaning it's not looking at a charge going from one lead to the next. It just has a positive charge only to it. AVR will view the base of the heart. So the lead that you have on the right arm views the base of the heart. The lead on the left arm views the lateral wall of the left ventricle. And the lead on the left foot views the inferior wall of the left ventricle. So it's seeing the bottom part of the left ventricle. The letter A stands for augmented. It says that waveforms are small, so they are enhanced or augmented. V stands for voltage, and then R, L, and F, right, left, and foot. So when impulses move away from the positive lead, it's going to cause a downward deflection. So that's not an abnormality when you're looking at the EKG. It's just a matter of where if the ventricles are depolarizing away from the positive lead, you'll see a downward deflection. And then if impulses are moving towards the positive lead, you see an upward deflection. Looking at AVF, impulses are moving towards the positive lead, and then you'll see an upward deflection. Okay, on the chest, you have your chest leads or precordial leads. They are also unipolar. It's just a positive electrode, and a reference point is calculated by the EKG machine.